Hello, everyone. This is Brian Slomovitz. I'm a gynecologic oncologist, and I'm the clinical trial lead for endometrial cancers within the GOG Partners Group of the GOG Foundation. And I'm so excited to be here with you today and really to have our year-end review for endometrial cancer. It's really been a very, very exciting year, not only with FDA indications for new drugs, but also with what I'd like to say is a really robust portfolio of trials that we're studying better treatments for endometrial cancer for all women who suffer this disease, from early adjuvant trials all the way to second-line trials and later. With me today, I'm really thrilled and humbled to be with Dr. Angela Secord. Dr. Secord is a professor of obstetrics and gynecology at Duke University. She's director of their clinical research program there. And in addition, for the GOG Foundation, she's co-chair for the Mentor and Education Group. So she's actually really been a great mentor to me in my career and a great friend. And Angela, thank you very much for being here. And I'm really, excited to talk with you, but more excited about talking with you about this particular area.
Absolutely. Thank you for having me, Brian.
So I know there's so much for us to talk about. Before we get going into the individual trials, Angela, share with us a little bit, as I mentioned, it's really been an exciting year for endometrial cancer. Looking back, what are some of your thoughts about some of the groundbreaking research that's been done? And how do you think that's really going to change, historically this past year of what we're going to do moving forward?
Yes, I would say this year started out with a bang in endometrial cancer. We had the press release, so we knew that the phase 3 trial evaluating pembrolizumab lenvatinib in patients with recurrent disease was positive. And it was our first plenary presentation at the March SGO annual virtual meeting. Dr. Vicky Macker did a fabulous job presenting this data. And so from this data, it really changed the standard of care. And how exciting is that when you leave from a meeting presentation and when you're going to see your patient next week in clinic that you're going to talk to them about a new combination drug that may help them control their disease better and live longer. So absolutely thrilling way to start off the year.
Oh, that's so, yeah, that was really a game changer for all of us. And in particular, while we're talking about where we are now, what about what sticks out in my mind is not only one, but two drugs we have in the biomarker positive group, right? If they're MSI high or dMMR endometrial cancer, we have two drug approvals. Do you want to just go through those two very quickly?
Right. And also, can I add to that, Brian, patients with TMB high tumors as well?
Of course, of course.
So those two drugs are pembrolizumab and dostarlimab, which were not only agnostic approvals, but also approvals for endometrial cancer. So we have two different choices of immunotherapy. And then on top of that, we have the option of the combination. Oh, let me back up. So those two drugs, single agent for the most part, is how I use them. For those select patients. And then the pembrolizumab lenvatinib is approved for patients who have cancers that are not deficient in MMR or are not MSI high, which is a little bit like the reverse, right? So so I think of that combination for patients with tumors that have proficient MMR and MS stable tumors.
Yeah, no, that's great. And I think as we keep talking about it, for the listeners, they keep reminding themselves, and it's a really good concept to grasp. And the concept is immunotherapy works in endometrial cancer. Okay, so it's an effective drug in endometrial cancer, whether it be pembro, dostarlimab alone, or pembro lenvatinib in those that are biomarker negative. And then one of the things that we're doing, and I think what I think we should really spend some time on is we're taking from that concept that immunotherapy works in the second line, and we're moving it into the first line. So right now, we have 3 active trials that we're accruing to in either the adjuvant or in the first line metastatic setting, looking at immunotherapy earlier on in the disease, which is something, I think in my practice, the earlier you use it, the better. Why don't we start off with the 2 metastatic trials? You know those well, the Ruby trial and the DUO-E. What are some of your thoughts and how those trials may change how we manage patients?
Yes, absolutely. I think your point is very, very well taken. So DUO-E is a trial that's evaluating standard of care chemotherapy with paclitaxel and carboplatin and adding on top of that durvalumab, which is another IO therapy. And then patients in the maintenance setting may receive olaparib or placebo. And the Ruby trial, which is now in part 2. So part 1 was chemotherapy with or without dostarlimab, also placebo controlled. And part 2 of that trial added on niraparib. So the group that is randomized to dostarlimab will also receive niraparib in the maintenance setting. And these trials are very important because they're now taking it, not just the IO portion, but adding on that other layer of PARP inhibitor therapy. There's some very exciting preclinical data that suggests that perhaps adding on a PARP inhibitor may enhance immunotherapy. And one way that it may do that is through the activation of the STING pathway. So stay tuned. These trials have really enrolled very well. And, we were talking earlier about the fact that we are running these trials at the same time within GOG partners. And at our group, we have the Ruby trial open. I know other groups have DOE open, but it just shows the power of this collaborative group and being able to run these trials simultaneously.
Yeah, no, I think that's a great point. And while you're speaking, the thought that comes to my mind is it really does take a team. And each one of our listeners, most of them are part of an institution that's contributing to these trials. So, we can't do this alone. We can't do this at 1, 2, 5, 10 institutions. This is really a cooperative group effort. We have over 350 sites in our GOG Partners cooperative group, and we really rely on a lot of our partners to get these trials done. So thanks for highlighting that. The adjuvant trial is one that I'll highlight. I'm working on that with the GOG Partners group. This is GOG 3053. It's B21. It's a Merck-sponsored trial, B21. What we're doing, even prior to having measurable disease, in the newly diagnosed patients who are at high risk for recurrence, non-measurable disease, stage 1 or 2 patients with non-endometrioid or high-risk histologies, or stage 1 or 2 patients with P53 mutations. Really the first time that we're incorporating P53 biomarker as an inclusion criteria for one of these studies. Or if they have stage 3 or 4 disease with that's completely resected, these patients are getting chemotherapy with or without pembrolizumab, a checkpoint inhibitor. Again, highlighting the role of pushing these checkpoints earlier and earlier into the treatment for patients and hopefully yielding a better outcome. And just what are your thoughts about, again, this at a trial like this, an adjuvant trial, and the effect it may have on our patients?
Well, Brian, you're the PI on this study. So I just have to congratulate you on an excellent design trial. I was thrilled to hear about this trial when we were first offered the study as a site. We sent out the feasibility survey quickly. It took us a while to get it up and running, but we now have it open. And I think this is a fantastic trial. One of the things that I think my partners appreciate, I certainly do, and my radiation oncology partners really appreciate is the ability to add radiation with or without cisplatin. That you have a lot of flexibility in the trial design that you all put together. So I think that this will be an important trial. You mentioned the other aspect, which is the biomarker aspect, and we'll be able to look at the study afterwards and evaluate the effect in the different subgroups.
Great. Thank you for taking part of it. And this trial, just for, if you're not aware, it's looking for 990 patients. So it's really a large effort, and we're actually accruing ahead of schedule. So I can't give out much more details than that, but I want to thank everyone who's participating for their efforts. Another
Brian,
trial, which
do you mind if I just mention one thing really quickly? Because I really, we've talked about 3 incredibly important trials: DOE, Ruby 2, and 3053 B21 trial. And these are all potentially standard of care changing clinical trials. And we also have the LEAP trial out there, which we might talk about, but they have the potential to change standard of care practice and potentially move immunotherapy up into the frontline setting, which you may be launching into this soon, but how is that going to change how we treat patients in the recurrent setting?
Yeah, no, that's a great point. And you're right. It's these 2 trials, the 3 trials. The LEAP trial, as you alluded to, was, and you talked such positively about the lenvatinib pembro data, may move that to the first line. I don't want to cut our good friend Ramez Iskandar short. His GY018 trial is another trial in the setting, looking at pembro with chemo in the first line setting. So it leaves wide open what's going to be in the second line. Let me start off, in those patients that get to the second line without IO, we do have a trial in the GOG partners, GOG 3038. We're partnering with Insight, looking at their checkpoint inhibitor in combination with other drugs in a biomarker-driven fashion. So there's actually two of the arms are single agent checkpoint, again, for patients that don't get in the first line. And the other arms are looking at either a biomarker negative group or a group that have FGF mutations. So that one's accruing nicely. I want to thank all of our sites for accruing to that. But that, again, this leads us to a wide open area. What should we be doing for those patients treated with IO that failed treatment? We have one study. I'll give a tease. We have a teaser. We have one study, GOG 3039, looking at Cdk46 inhibitors in an IIT setting in combination with letrozole. Share some of your thoughts. We keep complimenting each other, but you're really brilliant in this field, and I'm humbled to be working with you. What are some of your thoughts about Cdk46 inhibitors as a potential target or a therapeutic area in endometrial cancer?
Absolutely. Well, Cdk inhibitors, just for the audience, which many people probably know this now, they inhibit cell cycle progression, and that prevents the cell from proliferating, so kind of stops in its tracks. And so there have been two very interesting trials of combining Cdk inhibitors with letrozole. It appears as a single agent. This is probably not the best use of this drug, but in combination with the hormonal therapies like letrozole, there's some very promising signals. So one study combined it with ribociclib, and then the other study I really want to focus a little bit more on was a combination that was evaluated in the Paleo study. And this was presented by Dr. Mirza, I think 2 years ago, at one of the international meetings, and combined letrozole with palbociclib. And what they demonstrated is like over doubling, almost a threefold improvement in progression free survival. It was 8.3 versus 3 months. And the other interesting thing too, when you evaluate disease control in terms of a landmark analysis at, I think it was 20 or 6 months, you had disease control in over 60% of the patients who received the combination. So pretty nice findings there. And I think there's a lot of interest in exploring this area further. So far, there hasn't been a biomarker to direct Cdk inhibitors yet, but there is some interesting preclinical data, and I think people are still searching.
Yeah, no, that's great. And one of the things that's nice, and I think we should do better at, we're following the lead of our breast cancer doctors that have been using Cdk46 inhibitors for their disease. They do have some FDA approvals, but we're catching up, and we're finding that it probably is going to be a great target for us to work on in endometrial cancer. And without revealing too many details, I think it's fair for both of us to say we're going to be working a lot on this in the coming year. So, and I know with your leadership, we're going to be successful in these efforts.
I would say with your leadership, Brian, you've got your stamp all over a lot of these trials. So congratulations on your forward thinking.
It's our team. So what are you looking forward to? I think there's one trial. I want to hear your thoughts on this. There's one trial that's going on right now with our European colleagues. It's called the Dominica trial in MSI high tumors, measurable disease, to eliminate chemotherapy altogether. MSI high tumors, they're randomizing patients dostarlimab versus carboplatin paclitaxel. What are your thoughts, and should the GOG be doing a similar trial?
Well, I think this is the way it's going in the future, certainly in biomarker-directed disease. And can you imagine a world without chemotherapy? And I would say yes. I mean, we're there now. The LEAP trial may put the combination of Pemlyn in frontline over chemotherapy too. So I think it's really exciting to see what that study shows. And I am hopeful that the GOG partners will be doing a similar type trial, evaluating IO therapy versus chemotherapy in those select patients. I think this is a really important group that they may benefit from an IO therapy with improvements in disease control and overall survival, but most importantly, a better tolerated safety profile and maybe even better quality of life.
Yeah, no, that's great. And, maybe, in response to that, as a Christmas patient to our investigators and our patients, hopefully, we will be opening GOG 3064, our Merck C93, which is a very similar trial. MSI high positive patients will be treated with pembrolizumab versus carboplatin paclitaxel. Again, for most of us, you and I, getting rid of chemotherapy, a dream come true. And that's going to be a trial that one of the first trials we open up in the new year. So we're really excited about that.
Yeah, fantastic. Hey, Brian, you also just finished enrolling to the Siendo trial, right? Which is a very
Yes.
interesting trial.
Yep. Yeah, we're excited about that. That's the trial that's also led by Vicky Macker, looking at an inhibitor of a nuclear transport inhibitor. It was a maintenance trial, selinexor, following chemotherapy. Those patients had a complete response or a partial response treated with his maintenance therapy. We don't know the data. We're excited. You know, our job is to accrue to the trials, which we did. Now we're going to wait and see how it reads out. But that may be a game changer as well, particularly not strictly an IO therapy.
So Brian, there's all these exciting trials that are ongoing, many things to look forward in 2022, like the Siendo data, LEAP data, ongoing clinical trials with GOG Foundation, and your teaser for the new GOG Partners trial evaluating pembrolizumab and chemotherapy. I think it's really important to help sites if you're not part of GOG Partners. We're really inclusive. We want to bring people on board. And I think after this message, we'll have some information for those groups that want to join our team.
You know, exactly. Thank you so much. Thanks for your time. It's always fun chatting with you, and I'm sorry we're not doing this in person. But you know, for everyone out there, just to echo what Angela says, we need everyone's input. We need everyone's leadership. We want you guys to help not only run the trials at your sites, but come to us with ideas. And Angeles is doing a great job with the Investigator Council and with their junior investigators and her mentorship programs, the scholarships that are available, the funding that's available. So I know if you have any questions about that, just reach out to Angeles or Ronnie directly, and they'll lead you in the right direction. But yes, please join us. Most importantly, ready, Angeles? We're gonna say on three. 1, 2. Happy
New Year!
Happy New Year! A happy and safe New Year to everyone, and we look forward to seeing you in Phoenix in January or at the next meeting soon.
Bye, everyone. Happy New Year again. Thank you, Brian.
Thank you. Thanks. Bye.